All right, it looks like we have a good quorum of folks who've joined us on Zoom. Welcome everyone. My name is Alana Crum. I'm one of the inpatient chief residents here at UW-MC Montlake. And just as a reminder for everybody, if you have questions for our speaker, please feel free to put them in the chat and I will pose them to our speaker after the presentation. So I am very pleased to introduce Dr. Rudy Rodriguez. He is the Director of Hospital and Specialty Medicine at the VA Puget Sound Healthcare Systems and the Vice Chair of the Department of Medicine at the University of Washington. He's also a practicing nephrologist and serves as the chair of the VA-wide Renal Field Advisory Committee and the American Board of Internal Medicine Nephrology Board. And his academic interests include kidney disease, health disparities, and increasing diversity in academic medicine. And so I'm incredibly excited to hear his presentation on geography matters, residential segregation, race, and health outcomes. So Dr. Rodriguez, I'll pass the podium over to you and let you present to our folks here for Department of Medicine Grand Rounds.
Thank you again very much for the invitation. I was supposed to speak, I think, in March, but as all of you know, COVID came, but also the current civil rights movement that we're going through. So I think the talk is especially important at this time. And I've actually made it less of a nephrology talk. I only have a couple of slides and have changed it to reflect a little bit about what's going on. The disclosures, I really have no financial disclosures. I just want to make clear today I'm here in my role as a UW medicine faculty member and not as a VA staff member. I'm actually not on VA time now, took the day off. Views are my own. And from an ABIM standpoint, obviously I won't be going over any exam questions during this presentation. What I hope to do today is just tell you a story about segregation, tell you how we measure it, the history, and how it has impacted other social determinants of health and other health outcomes. And I'll explain to you what I mean or what is meant by this is us at the end. When I actually interviewed for the job here, when I moved from UCSF, San Francisco General in 2007, actually my first interview talk was on segregation. I was about to publish a paper about it that I'll show you at some point when I was being recruited here by Stuart Shanklin. And I must say it's been I guess it's not good to call it an interest. It's more I've always been kind of horrified by the whole thought of segregation. I grew up in San Francisco. Still remember as a kid wondering when I went to San Francisco Giants games, which took place in Hunters Point, predominantly African-American neighborhood, why that existed, or when I went to Stanford in East Palo Alto, 30 miles south of San Francisco, you have a very segregated little suburb. Or when I was in medical school at the UCLA Drew program, doing my clinical rotations at the MLK hospital in the middle of Watts, which at that time was still a predominantly African-American hospital. Or half of my career I spent in San Francisco General dealing with this population. Just want to say a word about the map, which you have here in front of you, which is from the University of Virginia. They've made these incredible maps from 2010 data, census data, and one green dot represents one African-American person versus one white dot equals white. And I'll go over some of these maps and explain them again when we were talking about certain cities. So the main measurement of residential segregation is the dissimilarity index. Here you can see the top would be a city with high segregation. Kind of the green would be the white majority residents separated versus a low segregation city. And this is a formula that looks at neighborhood racial groups versus the group in the whole city. And the numbers that come out are if it's 60 to 100, the level of segregation is thought to be high. 40 to 50 is considered moderate. Less than 30 kind of is low, kind of like GFR measurements. This is then here on the right, you can see the dissimilarity index in some of the most segregated cities in the country. The largest city, a large city like Detroit, is, and some of these are the cities that you're all familiar that are very segregated, like Milwaukee, New York, Chicago. Just for your information, Seattle ranks about 127, but the dissimilarity index is just a little bit above what would be considered high. This is what the maps look like. Okay, and I'm always interested in cities and then looking at these maps. This is Detroit and how segregation looks like in Detroit. Here again on the green areas are Black residents. And you can see a street right here where there's this sharp demarcation where people just haven't moved into. These are Hispanic and here Asian. And you can see little suburb areas, and this is something I'll talk about, that suburbs are not necessarily all white. In fact, 39% of all African Americans live in suburbs. But if you look at the segregation index, it's actually high. It's been dropping from 1980s, where it was 60 in the 60s, to 52 in 2010. Cities, where about 36% of African Americans live, remain really, some of the big ones especially, hyper segregated, and segregation hasn't really dropped. So let me go over a little bit about the history of racial residential segregation. We're obviously in this civil rights movement now. Thanks to the 1619 project by New York Times. I think everyone now familiar with that date when slavery reached our shores. And then I'm not going to go over this timeline, but I did want to kind of focus on the Great Migration, when 6 million African Americans in the South moved to into the Northeast, Midwest, and West between 1916 and 1970. Because prior to this time, actually, segregation didn't really exist in the US. This is something kind of unique and something that we created. One of the, I think, best nonfiction books I've read over the last 10 years has been The Warmth of Other Suns by Isabel Wilkerson, who interviewed somewhere around 1,000 people who made this migration. She then kind of followed three individuals that, one made the migration from Florida to New York. Another one, the female in the book, actually went from Mississippi to Chicago. And then one is a physician who went from Monroe, Louisiana to Los Angeles. And kind of tells some of these heartbreaking stories, like Robert Foster, who's a physician. When he finally left the South, actually drove, and once he left Texas, he thought he had left the Jim Crow South, but de facto segregation still existed. He actually would stop at some of these hotels in Arizona as he was driving, and although they didn't have signs, but they were almost full, although that was just a story. Also, just wanted to, I'll be kind of referencing the Civil Rights and Labor History Consortium here at UW. Professor Gregory's done a great job. One, he has an academic history of writing on the topic of the Great Migration, but has some great, I would encourage you to visit his website. Hopefully some of you who were here 2 years ago were able to go to the Seattle Art Museum and saw the Jacob Lawrence Migration Series, which kind of depicted elements of the Great Migration, from why people left the South, from lynchings and the courts, to some of the tenement housing that people came to here in the Northeast, and then some of the violence. The reasons for kind of our current residential segregation is, not by choice. Enclaves are kind of refer sometimes to immigrants, international immigrants that come and live in communities like their own, which is sometimes helpful, and can leave. Segregation really happened because of racism. Like I said, that's something was new to the U.S. Before 1917, actually, there were laws that actually that mandated residential segregation, but it was found unconstitutional in 1917, not because it was wrong, but because white people were deprived of the ability to sell their property. And the reason it really exists is some government and business policies. During the Great Depression in 1937, the Federal Housing Administration and the VA actually started giving out insured loans. And for the first time, started the whole concept of amortized loans, which if anyone purchased a home, you can pay into your principal and your interest. Prior to this time, you would pay interest and then have a huge balloon payment at the end, and that's why most people didn't own homes. And part of this were redlining maps that I will go into. The National Association of Realtors even had it in some of their bylaws of how real estate should not be sold to African Americans at this time, because otherwise it would reduce the properties in some non-segregated areas. And I'll talk about covenants, which were in existence until 1948, and explain blockbusting, public housing, and of course the history of violence. This is relatively new. In the University of Michigan, the Digital Scholarship Lab, and Virginia Tech and University of Maryland have digitalized redlining maps, and you can now kind of get to these and actually conduct research. For instance, if I would go to Seattle and click on Seattle, it brings up the redlining map of Seattle. And this, just to orient you, here is Jefferson Park, where the VA is. UW would be over here. And this is basically then, the central district. And this is kind of what this map looks like now, where, to date, still predominantly African American. And just like I showed you in Detroit, there's, like many of you know, the road up here, whereas you go towards the lake, it's predominantly white and expensive housing. And you go to the other side, it's actually less expensive. And remember, this is where a lot of us get our wealth, is from homes. So this is one of the reasons wealth has escaped the African American community in these neighborhoods. Chicago is one of the most famous cities for segregation. And this gives you an idea of, here in the green, the African American population in South Chicago, West Chicago. And this is the redlining map, indicating here in red that this is a hazardous area, and that loans, these amortized loans, should not be given to people or homes in this area, which then translate to an area now where we see that this is still mostly African American. And that was, again, and then this is Hispanic areas here now, and then Asian. And again, I think it's important because although redlining, like we heard in the lecture last week about environmental or climate change, that this is not just history, this explains why we are where we are today. As far as restrictive covenants that were in place until they were struck down in 1948, these are covenants that in homeowners, and then this is again from the UW Civil Rights and Labor History Project. They've actually gone into homes, and you may be living in a home where some of the paperwork for your home actually still has some of this wording. Like in Capitol Hill, these properties still have that no part or said premises should ever be used or occupied or sold, rented or given to Negroes or any other persons. This became illegal in 1948. Before that, you could actually sue people if they sold homes to African Americans. Remember, this is a time where even here in Seattle, Boeing would not employ African Americans. This project actually led to the changing of Washington law. So if you find this paperwork in your home, you can actually have it taken out of your deeds. I mentioned kind of East Palo Alto, which is about 30, 40 minutes south of San Francisco. And it's just predominantly white. Stanford University is here. It's one of the richest areas, the Facebook campus of today and the Google campus here. But it's predominantly African American, and just the reason it happened is something called blockbusting. In 1954, one black family moved into this white-only area of East Palo Alto. 6 years later, East Palo Alto is 80% African American. When I was an undergrad at Stanford, East Palo Alto had the highest murder rate actually in the country. And the way this would happen, this blockbusting, would be real estate agents would actually pay people to African American to go in here into the city, pretend they live there, drive around in cars, would try to scare white people to move out, buy the homes on the cheap, and then sell them an expensive rate to African Americans. And then from a history of violence, this is Anne and Carl Braden here on the left. Anne Braden actually was a civil rights activist who was originally from the South but hated segregation. They bought a home for Charlotte and Andrew Wade and their daughter. Charlotte Wade actually just died earlier this year. They moved into the house, and actually the house had cross burnings, were shot into, and at some point when they weren't in the house was dynamited and blown up. And this was not uncommon across the country. And although, again, this may sound like history, I think all we have to do is look on kind of social media when people now move into areas that are mostly white and look at the way they're harassed. So it is historic, but things change but haven't disappeared. This is a picture of Martin Luther King when he was hit in the head by a rock. And this is after the Civil Rights Act was passed in 1964, I think, or 5. The last 2 years of his life, Martin Luther King was working in the Chicago Freedom Movement, working kind of on segregated housing in Chicago. And he actually said that he had never seen so much racism in Chicago, that it actually was worse than what he had seen in the South. And it was because when it came to having African Americans move into white neighborhoods, that it really brought out the worst in people. Just a side note about, when we talk about segregation in medicine, we always kind of, or about racism in medicine, we always bring up the Tuskegee syphilis study. But I think there's a lot more to choose from, like the fact that during this time, white female nurses, couldn't take care of African American men. There were separate wards for white and black patients, usually in the basement, separate hospital entrance. Treatments were available for African Americans, but only after white patients were treated. The AMA was actually known for discriminatory practices against African American physicians. They eventually apologized, but it wasn't until 2008 actually that this apology came. And of course, medical schools were created because African Americans were not allowed into other schools. And another interesting note is that our own Medical Civil Rights Act was actually Medicare and Medicaid. The Medicare Act actually threatened to withhold federal funding. And I'll mention a book at the end of the talk that describes like Grady Hospital, where a night before this went into effect, patients were just moved around the hospital and integrated because of this threat of federal funding loss. This is from Seattle to remind us that it's not that much better, our history. This is a letter from Regina Mason from the Director of School of Nursing saying, in regards to our policy, we do not accept Negroes or Japanese. Or this complaint letter that here in Seattle, and complained about how Swedish Hospital will not receive Negroes at this time, and mentioned some of the other practices. Not sure how much this is true, but again, this is from the Civil Rights and Labor History Consortium here at UW, and this courtesy of Professor Gregory from the Department of History. So let's a little bit quickly review the history. This is one of my favorite prints I saw here at Catherine, at one of the galleries here. It's a huge print, wood print, 40 feet long, with the procession of progressives, progression of conservatives, and this in the middle. So it takes up a huge, just a reminder that we've come a long way, but we have a long way to go. So a little bit about the determinants of health, and this is from a figure I borrowed from Yoshio Hall's paper that he published in the American Journal of Kidney Disease, talking about how medicine or the health of our patients is really affected by economic stability, education, health, kind of their health insurance, community networks, and again, the neighborhoods they're in. Part of one of my message today is that this is a huge driver of a lot of these other social determinants of health. As far as some of the evidence, we know that income is associated with life expectancy. We know that education is associated with life expectancy, health insurance, and segregation. For example, with education, I don't know if people realize this, but our schools remain just as segregated as they did since Brown v. Board of Education in 1954. More than these here in the dark areas are the schools with very high segregation. And I think more importantly, school districts that predominantly serve students of color, so including Hispanics and Native Americans, receive about $23 billion less in funding than mostly white schools. And again, this is true even here in Seattle. We're considered a high segregation school district, meaning there's segregation between Black students and white students is very high, partially probably explaining why Black students on average are 3.7 grades behind white students in Seattle. And again, with a lot less funding. This also probably explains the wealth gap. This is from a fascinating study that looked at the tax returns of families 1978 to 83, saw if kids were born into rich or poor families, and then looked at what happened 30 years later when the kids were adults. And you can see Blacks remain fairly in the same income percentile compared to white children. Native Americans had almost no increase in wealth, and there is some wealth increase in Hispanics. To look at it a different way, the study then looks at how Black boys and white boys is compared if they're born into a poor family. White boys actually will become more likely to become rich adults, while Black boys are more persistently grow up to be low middle class adults or poor adults. And that's 70% of and Blacks end up in these lower compared to about 50% if born poor. And it's not much better if you're born rich family. Rich families, if you're born Black, which is pictured here in the blue, you tend to actually drop in your when you grow up into the 30s, something like 50% versus 20% in white boys. And this explains, this big wealth gap between white families and Blacks that only have a kind of a accumulated wealth of 13,000. And this wealth gap even persists, as you can see here, in advanced degrees. So things have not changed much since 1968, and a lot of it, again, I would argue, is about this housing and about segregation. Because if they weren't able to buy homes back over the last 50 years, that's where a lot of families get a lot of their wealth. And remember, that was subsidized housing. So I would be remiss not mentioning mass incarceration, I think. Here on the right are all our European countries, Australia, New Zealand, and this here is US, and the incarceration rate per 100,000. We're really an outlier in the world. And this is especially true in Black men. So Black men born in 1965 to 69, and if they're high school dropouts, they have about a 60% chance of imprisonment, and in all Black men, it's about 20%. And this is kind of the argument in the new Jim Crow. So if people haven't read this, I would encourage you. Part of our argument is that one, it was laws and kind of the war on drugs. So I don't know if people know about the 1 to 100 sentencing rule. So if you're caught with 1 gram of crack cocaine, you have a mandatory 5-year prison sentence. But powder cocaine, it's actually 500 grams to reach that 5-year prison sentence. And whites in general use powder cocaine compared to crack cocaine, which is much cheaper used in the Black community. That's the argument made about why there's a big discrepancy. But the big message, I think, in the new Jim Crow is that in this country, we have about 200 million, we have about 2 million people in prison and about 20 million felons, again, predominantly African-American men. And that actually means that once they're felons, they're disenfranchised, can't vote, harder to get jobs, harder to buy homes. So this is also connected to homelessness. 8% of the LA County population is Black, 42%, 42% of the homeless population is Black. 60,000 Black residents in LA experienced homelessness in 2019. And LA is mostly responsible, Los Angeles mostly responsible for the national rise in homelessness. And prison-wise, 30% of the prison population is African-American, again, only 8% of the population. Here on the right is kind of Watts Willowbrook in the 1970s. And you can see this is the share of the Black population. It was predominantly African-American population. And these were red line districts. This is 1980. 90s when I was there, or right around when I was there, 2000. And you can see African-American population is no longer the predominant population in this neighborhood. It's mostly Hispanic at this point. The Latinx population has moved in here, increased prices, and really has left kind of a lot of the African-American population there without a place to live. This is Skid Row, which is the actual name of it, not a derogatory term, but that's what the signs in the neighborhood show. And this is what it looks like. There are just camps everywhere. So I think next time you're in LA, I would encourage people to drive through this area just to see kind of where the largest homelessness population lives, although we have obviously a huge problem here. So let me get to some of the health outcomes. And I'm sorry, I'm not going to spend a ton of time on the individual studies. Again, I'm just trying to give you a flavor of what this looks like. I'll start off with the fact that Blacks actually have a higher age-adjusted death rate overall. You know, this is independent of segregation compared to whites, and much lower death rates in Hispanics. So Black death rates in the country are in the mid 800 per 100,000 compared to whites, which are lower 700 per 100,000. If you look by cause and look at the death rate disparity, it's increased for Blacks, the mortality rate in almost all areas, dramatically so in homicide rate, HIV. The only times whites have a higher mortality are unintentional injury, which includes drug overdose, and suicide rates, especially in white men. If we think about COVID, it's become number 3 on here with a death rate of about 88 per 100,000 for Blacks and about 40 in the white population. The death rate in the age group is 65 and above, actually, over time between 1999 and 2015 has actually come together. So that's actually not a big disparity. The disparity is in kind of the younger groups, especially between 50 and 64 years old. If we look at ages 18 to 34 in African Americans, you can see this is a line for homicide rates that's contributing a lot. Unintentional injuries, again, accidental drug overdose. And then this is accidental drug overdose in whites, which is high. And if you look 35 to 49, already you can see that cardiac disease is high, and so is cancer, less so than in whites in that age group. And that's from, this is from CDC data and looking at death certificates across the country. Trying to see how much a contributor segregation is, they use the dissimilarity index here. And in these models in men, these models start putting in, for example, household income, and then finally here, socioeconomic index. And although it explains some of the disparity, there's a strong association between segregation and the white-black survival gap. So it's a strong contributor, even when you control for income, education, and other social factors. I think it's segregation is very different in every city, so I just wanted to focus on where the disparities worse, and that's in Washington, D.C. Washington, D.C., well, before we see that, I just want to explain this. This is life expectancy. This is in Black men nationally, is about low 70s, and for white men, it's 74. If we look in Washington, D.C., for Black men, it's about 68 years of life expectancy. For white men, it's in the high 80s. There's a huge, almost 20-year difference in Washington, D.C., huge difference between national data. This is for women here. As you can see, there is a difference, but not as dramatic. The other thing I would point out is that this is not closing, right? It's actually widening. And we can only imagine with COVID that this trend will actually widen even further as far as the gap. This study looked to see in DC, Washington, DC, kind of what contributed. They did an age and cause decomposition, meaning they wanted to see how much of an increase contribution homicide or heart disease. The highest contributor, especially when they see on age group, was in homicide rates among men. Heart disease was second, and then you can see neoplasms. Here on the right is women, with contributors from the gap in Washington, D.C. being heart disease, neoplasm, and again, unintentional injuries also contributing. So to show you a map of what Washington, D.C. looks like, this is where many of you probably have gone, in the National Mall, and this is where we are very familiar. This again is the Black population in green, which are these wards in Washington, D.C., 8, 7, 5, 4 here is mostly Hispanic. And this is, again, is a show of the mortality difference in these geographic areas, where here in the light color, the life expectancy is about 72. Here in the high 80s, where it's mostly the white population. I'm going to flash a bunch of maps quickly just to show you then these social contributions to determinants of health in these neighborhoods. So this shows you percentage of adults with less than high school diplomas highest in this area. Unemployed population is highest in these Black areas. Percentage of household income gap when you pay rent for gross rent is highest in these areas. Public assistance is highest in these areas. Health insurance coverage is lowest in these areas. And when you look at violent death, it's highest in these Black neighborhoods. So again, it's dramatic. I think this disparity between whites and Blacks, and when you look at COVID, this is early in the pandemic in April. The highest death rate was here in Ward 8. Again, this again just the orange hue is kind of where the mall would be, where the Capitol building would be. These are the areas where people don't visit, which are predominantly Black areas, and this is more recent data just showing the higher number of deaths in these areas from COVID. So just a quick review of the other data that's been published, and I wanted to make this kind of a general talk, but I would, depending on your interest area, there's actual data on residential segregation. So just kind of picking a few, like cardiac disease, which has shown that there's a decrease, there's an increase in hypertension in these areas. The cardio study is interesting because it measured a certain population in the 1980s and has followed them over time. They actually showed that for people that moved out of segregated areas, there were differences in blood pressure, so lower blood pressure in people that moved out of segregated, Black people that moved out of segregated areas. The MESA study has shown an increase in cardiovascular disease that correlates with residential segregation also. Leah VAPSHCS, who had been here at UW, did a study looking at mortality from lung cancer. She also showed that in areas with high segregation, the mortality rate was higher compared to moderate segregation and low, and no difference really in white patients. Other important findings, there's an association with air pollution exposure and segregation. Last week we heard about climate change in these areas, blood levels, air pollution. Again, I think there's a theory that it could be contributing to COVID-19 mortality. And these segregated areas are usually found in the worst parts of towns, next to shipyards, next to factories, with a lot of pollution. My own work that I mentioned when I started we looked at not necessarily segregation, but really we looked at zip codes and the percent of patients that are Black in those zip codes, which is a little bit different than segregation. I won't show you much of the study, just to say that we initially found that transplant rates in predominantly Black zip codes, so greater than 75%, whether you're white or Black, had a lower transplant rate than if you lived in a zip code that was less than 10% Black. So a big disparity among transplant rates if you lived in these predominantly Black neighborhoods. We also found other things like dialysis units, which had higher mortality, SMR, standard mortality ratios, if located in these areas. A few years later, someone else, Paul Kimmel from NIDK, did a similar study. He actually also showed that as you went from low to high residential segregation, the mortality rate, the hazard ratios for death actually increased, where there's no difference in whites. I forgotten I had published this, but there was a paper we looked, which was mostly a review paper, just talking about how important doing some of these geographic studies are. This isn't in the paper, but just looking at Google Maps and then looking in Chicago, just to orient you again, this is the south side of Chicago. If you visited Chicago, this is probably where you were, where the downtown is, South Chicago and West Chicago here. And this is just mapping where all the 5-star facilities for quality are in Chicago. And despite the large number of dialysis units here, they're all located in not in the predominantly segregated areas. So obviously our moments about some of the violence, and these are just some. This is Emmett Till here, who John Lewis said was his George Floyd. He's was the son of the Great Migration. His mother, who had moved to, I think, Chicago, sent him to Mississippi to visit relatives. He was murdered and sent and thrown into a river. His mother actually had an open casket funeral for him that was photographed by Jet magazine, because she wanted everyone to see what had happened to her son. This actually led to some of the, I think, the anger that led to a lot of the civil rights movement in the late 50s and 60s. Lots of times when I see these people killed, I will look and map kind of where they live, because many times they either were in white areas and thought that they didn't belong, or were actually in some of these segregated areas. A group out of Boston, from Boston University, published 2 papers looking at residential segregation and fatal police shootings. This is again the segregation, the index of dissimilarity with, remember, in the 80s being very high. This is the ratio of white fatal shooting rates. So in Chicago, black fatal police shootings are 57 per 100. White is 1.7 per 100. I've included Seattle just so you can see that our rates here are 105 versus 23. Interestingly, they saw that when you looked at segregation, and for every standard deviation increase, there's a 44% increase in police shootings. Not that intuitive, but if there was a big increase in African American residents, that was actually protective or decrease in shootings. The authors thinking that maybe some of these cities with a large black population, like in Atlanta, have a lot more political power, and maybe that's why we don't see as many of these shootings. The same group from Boston University looked at firearm homicide, and again looked at index here for segregation, and looked at the adjusted firearm homicide rate. They also found that as segregation increased, you would see this disparity in between black and white firearm homicides. And this is not hard to understand why it happens. You know, here's St. Louis. Here is a predominantly in the darker area, higher percentage of black residents, and every dot here is where a black person was shot. As you can see, it mostly is happening in this area. And again, this is in these other maps. This is what it looks like. This correlates to this area here. This is a red line map, which correlates to this area here, where African Americans could not actually obtain loans because they basically lived in their black neighborhoods. And these in yellow were marked as areas of transition, where also were high risky loans. Just a quick word about Ferguson, which is again another is an actual suburb. They actually had a similar story like Palo Alto. And remember, this is where Michael Brown was shot in 2014 and kind of left, his body left on the street for hours and hours for people to see. This again is suburbs become, black. So although people live in some of these suburbs, move to the suburbs, they quickly become mostly black. And then there's just a high, what happens is that then education, the financial base of these neighborhoods starts to drop. There's a white flight many times. And then with increasing crime, a lot more pressure and hyper vigilance from the police. Just a quick word about, I think, violence, just to put it into context. These are the highest intentional homicide rates in the world. El Salvador has the highest. This is actually where my parents are from. High enough where when I was invited to give a talk down there a few years ago, I said no because I was being called about the danger. This is what the international homicide rate is for the United States, so much lower. Chicago, it's 22. But to put into context, when we're talking about young black men, these are the total deaths in these places like El Salvador, which is a small country. We have about 16,000 shootings. Just to put it in context, though, if you're a black adolescent in Chicago, your homicide rate is about 665 per 100,000. To give you just an idea of what it's like living in that community. Probably a good time to give a shout out to Fred Rivara, who in pediatrics, who spent his career studying gun violence, which is not easy, as you know, in this country. So just wanted to talk about addressing the problem. Sorry about rushing through a lot of that, but again, I just wanted to tell a little bit of the story. When I still remember when I gave my a poster for the study I showed you in dialysis units and segregation. I still remember standing in front of the poster and having these guys in blue suits come up, look at it, and like one guy I still remember said, "Typical San Francisco study." That's when I was still working at San Francisco General before I moved here. Another guy said, "Yeah, but what are you going to do about it?" as he walked away. I've given this talk, like I said, to nephrology and over at the VA. I don't always like getting feedback from my talks, but I always get unsolicited feedback, and I still remember someone saying, "Oh yeah, I wish Rudy would have talked more about what to do about the problem," and that is difficult to know what to do about this problem. And I think it's difficult. I think this is resonated when I heard Eddie Glad, Professor Glad from the African American Studies in Princeton. He was on the news one time talking, and this had to do at the time of the El Paso shooting. But he talked about how many of us are kind of lost in the legends and myths of the United States, meaning we think the American dream is still alive. But he said, this is us, and if we're going to get past this, if we're going to get past racism, we can't blame it on him, meaning kind of our, the president or an administration. He's an administration of the ugliness that's in all of us. I think I resonated because I think that's what we have to do to change. Because the American dream, is not necessarily possible for a lot of people in these segregated areas. Like Martin Luther King once said, it's kind of cruel to tell someone to pull themselves up from their bootstraps if they don't have any boots. So I think this is about us. It's an important time for us to talk about health equity, how our medical center will respond. And I think many of you heard Paula Houston's talk earlier this year about what UW Medicine plans to do. And everyone is working on diversity, inclusion, making sure we're not a racist institution. But I think there's just so much more to address, and I hope that we think about everything from housing segregation to health insurance, and from gun violence and incarceration. And I think there's a role for physicians to work on this. I know it's daunting, but it should be part of what we do. For those of you that want to get into the weeds, I think you can look at this Metropolitan Planning Council. The Chicago in 2015 studied the cost of segregation, has come up with a plan. So if you want to get into the weeds about what a city can do, this is a great document to review. I just wanted to talk a little bit more globally about this whole thing, about This Is Us, and how I think the way people feel needs to change, and to make some of these bigger changes in our society. One, I think it's important to kind of stay politically active. Wanted to say a little bit about the Fair Housing Act, which was passed in 1968. 1968, it passed. There was a lot of pushback to passing the Fair Housing Act, but when Martin Luther King was assassinated, it was passed about a week later. The Civil Rights Act of '68 included the Fair Housing Act. Unfortunately, that Fair Housing Act had no teeth. And that's why, if you read this tweet here, it said, I've rescinded Obama Biden's AAFH, enjoy, or Ben Carson said this AAFH is a mandated social engineering scheme. And I sometimes agree with the social engineering scheme, but that's mostly to think about how segregated communities became segregated, not how we're going to attack it. So hopefully, this can be changed. I think at some point, the Fair Housing Act has to have teeth. Currently, if people file complaints, it has to go through this whole process through the Justice Department. And so there's not much avenues for redress in the current Fair Housing Act. That again was passed 50 years ago. So hopefully we can the affirmatively furthering Fair Housing Act rule will hopefully at some point be revisited, but at this point it's been rescinded. And again, I've been going back to how we're not in liberal Seattle. It's not that different. In 2011, civil rights testers were sent into rental housing. In other words, white people looking at rental housing, black people looking at rental housing. And about 50% of the time, there were problems, including being quoted higher rental prices for black testers versus white testers. Just last week, I think you may have seen this in the UW News, in the Department of Sociology. They did a review of the social or the rental ads and how they're written and how they're racialized. And there was a survey done in 2016 in Washington that asked whether or not blacks would just be as well off as whites if they could only try harder. 55% of Western Washington agreed with the statement versus 42 in the east of the Cascades. So, and I can go on with other examples. So I think some of the, just quickly, some of the examples I think around the country. YIMBY is a good one, which is Yes in My Backyard. And there's this nonprofit actually I think is working in Seattle. It started in Lafayette, California, which is a suburb, commuting suburb, San Francisco. And it's incorporated and mostly single family homes. And they wanted to build a 300 unit apartment building here. And as you can imagine, the residents of Lafayette came out and didn't want that there. They didn't want people moving into this area. And what YIMBY does is it sends people to these city hearings to talk about the kind of people and give a voice to the people that could benefit from this. But I think it's more a reflection that people don't want their communities to change. And again, that's what's been in the social media and some of the fear that's out there. There's a good book that it's actually waiting for me to pick up at our local bookstore called Golden Gates: Fighting for Housing in America, that explains some of these pressures. In California, 8 new jobs are produced for every new housing unit. So it's no surprise that they're having the homelessness problem and other issues, especially with segregation. Single family zoning is another issue. I'm not sure if you realize this, but Seattle, about 70% of Seattle is only single family zoning. So in other words, you can't build a duplex or a triplex. Minneapolis became the first city to allow anywhere in Minneapolis to build duplex and triplex. And that's a movement going through other cities. And here in Seattle, it's under consideration. But again, these are the kind of things that are voted down, even in liberal cities. Gentrification is difficult, but just wanted to highlight one project in the Central District, which is a nonprofit, built some low-income housing there. Part of the requirements to get a housing there is to actually prove that you have roots to the community, that you actually lived in that community in the past. There's a movie that came out actually yesterday that's now available on Netflix called, what's it called? Residue. I haven't seen it yet, but that's what it talks about, how difficult gentrification is, because unfortunately when you're attacking segregation, these communities become gentrified. Schools is another thing, just the last thing I wanted to mention. There's a lot of things we could do, including this New York Times article just highlighted the fact that parent-teacher associations have in one school district raised $1.7 million, and compared to about $1,800 per student, which comes out to about $1,800 per student, compared to the Bronx, where their fundraising came up with $11 per student. Portland has already come up with a system where this money is shared. So for those of you that attend auctions for your schools, just something else to think about. UCSF has a Center for Vulnerable Populations, they received $30 million from the Benioff family who owns Salesforce. I mean, ironically, the Salesforce in San Francisco contributed to the homeless problem, but they were giving $30 million to actually study it and look at different housing initiatives. Again, other things that I think that medical systems should be looking at. Wanted to end here with Irene Triplett. She actually died in May 31st of 2020 this year. Her father had her when he was 80, married a 20-year-old woman, I guess in 1930. He actually was basically then a teenager probably during the Civil War, her father, and was a Confederate soldier, then a Union soldier. Irene Triplett actually was receiving money, like a pension, up until the day she died. She was the last remaining descendant from Civil War. Reason I bring her up is I always think about her when people talk about reparations. People always say these things happened too long ago, but again, it hasn't been that long, and I think we can still see the remnants of what happened. These are some of the books I've read in the last year about some of these topics, and encourage people in case you're interested. I won't summarize what I just talked about, but happy to take a few questions with the time we have left.
Thank you so much, Dr. Rodriguez. That was an incredible overview of a really tough and poignant topic. There are a number of comments in the chat, and I encourage people to add questions as they come up that I can pose to Dr. Rodriguez. But one was just an overwhelming comment from some of the audiences that really the data you presented with the life expectancy maps overlaying of the demographics were really eye-opening and remarkable. So there is a lot of appreciation for you presenting that data. But there's a comment of could you comment on living in unsafe conditions and the relationship with inflammation and disease, if you've been aware of any of those studies or could comment on any of the research that's been done recently.
Not specifically, but yeah, there is a growing literature that this is, living in these kind of conditions, living in this kind of stress. Think about the teenager with the teenager, and then with the risk of homicide. So I don't know it well, but there's a literature that this is contributing to inflammation and kind of permanent changes. One of the slides, since I had so many I pulled out, was from a study done that looked in Boston at redlined areas, and even people that moved out of those areas, just had a higher risk much later on of developing certain cancers, even if they actually improve. So just even an exposure early on. So there is a growing literature, not unexpected.
And there's another question of, as physicians, is there one thing that you want us to take away from this topic moving forward to better care for our patients?
Yeah, I think it's, I think we just have to do more, and I think it's, you may have a 30 minute visit, but I think we've had other talks about how all of us, if we really want to make a difference, have to do things from creating these centers to study some of the issues I talked about, or obviously voting, making a difference, because it has huge impacts, or getting involved in some of these nonprofits that are trying to make a difference specifically in these neighborhoods. But big thing is that just to keep an open mind, and when it comes to making decisions that will impact yourself and your family and your wealth, that's when things, I think, hit the road, and sometimes people need to kind of look at what part we're playing in this.
Fantastic. I think that's a really wonderful note to end on. And again, thank you so much for this really, really great presentation on an incredibly important topic. So really appreciate you adapting to the new style and rescheduling in the setting of a pandemic. So thank you so much, Dr. Rodriguez. And Thank you to all of our participants and folks who attended. Just a reminder, we'll be here at the same time next week, and our topic will be updates in primary care with Dr. Golub and Dr. Overland. So hopefully we'll get to see you all there. So thank you all, and take care.